All right, dear doctors, this is your mentor, Dr. Shahriar. Let's go and start the session without any further delay. And please comment in the comment section is like everything is visible and the voice is clear as a loud and clear. Please mention in the comment section if everything okay. Mention as a loud and clear. That'll be really great. Okay, all good. Okay, good to know. Good to know. Good to have all of you. Some probably has gone through our um, some courses already 5 months there we had discussion with theory recalls, but this one is more extensive. This is more related to month-wise recalls actually. As you can see in C1, it's recalls. So many recalls we do in the live classes. We do usually more than a year recalls, and through the drive we also give you another 5 years actually, so nearly it's like a 6 years recalls. During the class, you will also have the drive access, and after the course, you will also have the drive access of the recall files, recall videos. I'll be demonstrating the files, how the files look like, and how the materials looks like in very short time because still a lot of doctors are joining the particular session actually. All right. Now, in the beginning, I would like to know from you guys, like from which city or country you are attending this particular session. So can you guys let me know, like from which particular city or country you're attending this session? And thank you so much to those people who already joined us for this course, and some of them I think after the session which we are taking today will be joining actually. And we have been taking classes very since 9 years, and you can see already it's more than a 1000, it's nearly 1800 has passed. Like if I count the AMC and another, I think 300 plus past the PLAB as well from the courses. I mean, I'll come back to the schedule, stay with us. I'll be discussing the schedule. So it's starting today. So this is 18th of April, and this one, is scheduled somewhere till including mocks and all these things till 30th of June. I mean, there's a routine with a 20 June scene, but there's some exclusive videos in the drive and in the video channel. So all together with the big mocks, so it's all together up to 30th of the June. So this batch is very much suitable for June, July, August, September, these people. There'll be another batch in the month of September targeting the November and the February. Okay, so you can join courses as per your need. So we'll be fine actually. And there will be also access to the recalls, like, even after this batch is finished. So good luck with that one as well. All right. Now, in this one, actually, it's a comprehensive recall. So 1 year class, in the live classes, live and plus the ongoing classes, including, a lot of people ask me a question, doctor, do you also take exam support? I mean, we are the only first people to start taking classes during the exam days, actually, which I was known for, actually. So it was already included. I mean, we don't charge separately for that one. Also, it's part of the thing. There's two, three, four classes, depends on the months, depends on the file, and probably like 7, 8, 9, 10 files we manage to post. Depends on which month people are going. So that's one of the thing. And I appreciate, like, you guys are taking interest in MC. And in terms of Australian healthcare, I know at least one, two doctors in every hospitals in Australia. They were my students before, that's which is nice to know. And we have a large community, I mean, which probably also very helpful in terms of networking in future, actually. Great. And another 5 years files and the SMA notes, videos would be given, recording would be given, practice mocks would be there, like smaller size, and also same like the exam, some mocks will be taken as well. Right. Now, as we mentioned, this is the class time. As you all can see, the class times are like, this is the class time you are joining. So in this particular time, I think we'll be taking the classes regularly, Monday and the Friday basis for the recall course, actually. So 6 year recalls live, assignment notes plus recall. I mean, this is the thing. Again, I mean, just to set you in your mind, like, so that we don't get more questions. So live class, yes, after class record will be given of the same classes, material access even after the close. We have some amazing references, which I will show you one of the file. And yeah, SMA, we have a full note that helps with the theory as well. Whereas some doctors also came from more theory batches, they have more extended knowledge on the theory, I believe. And mock test, some of the mock test actually, I mean, we'll be taking, which will look like the main exam with the timer on actually. All right. And of course, exam support group, this is included, and with the 6 years records file and the high quality videos will be there. All right, what's new actually? All right. Now I'll be taking you guys to one of the file which I'll be demonstrating. I'll tell you what's new here, and stay with us. Like, I will demonstrate you guys how the material looks like in the drive. So for that one, you have to be till the end. In case if I forget, please remind me maybe during break time or at the end to demonstrate the materials. So those of you already joined will get to know, how uh, things are done actually. So with that note, and we're going to start now. And as we mentioned that this is our class routine. We'll come back to this one again. So yes, like orientation and also material distribution. Already send materials to a lot of doctors. I think tomorrow morning I'll be sending the other doctors the materials actually. I mean, those of you who are joining. And this particular month, the admission will remain open. All right. As you mentioned, you can join now. You can join in next 7 days. Will be fine. Okay. With that note, without any further delay, let's get started. Yes, so this is we're going to do June. So June up to another coming June, we are solving actually. All right. So this is the first question. I will be reading the question and I'll give you a little like 10 seconds of time to finish that one. So that'll be really nice. All right. So in this way, we'll proceed and it will be more fun. So try to take interest in this class as more fun. And this is more like a standard question. And we have been always very up to date. One thing we can assure you, like we are the most up to date academy in terms of the recalls because I also take exam support group classes. So I have to demonstrate recall every month actually. All right. Okay. Today's first question. Are you guys ready? Let's bring some positive energy before we start. Can we bring some positive energy? I mean, as a commenting as a yes. All right. So that'll be really nice. I know some of you are faster because that was not a difficult question, probably. And let's get started. Okay. So an elderly patient presents with a vomiting for 4 times in last 24 hours. No constipation. Interesting. With a recent history of a gastric surgery. Now, if there is a history of surgery and the patient is having vomiting, maybe it is indicating some sort of obstruction. It's a possibility. Okay. CT scan reveal large. The main finding is here. CT scan, the radiology finding. Radiology finding, if it is given, that's surely quite a confirmatory. So dilated bowel. So this indicates certainly a obstruction, intestinal obstruction. Now, if it is intestinal obstruction, in that case, which type of intestinal obstruction can we guess? Can we guess from the history? Now, we do have a clue here, this part, because there was a surgical history. And if there is a surgical history, but still it depends on the CT scan and its location. But I think with the history and the CT scan, so I think we'll go more with the small bowel obstruction. One, history of surgery. One, history of surgery. Second, uh, CT scan finding mentioning dilated lobes with air fluid level. This is indicating obstruction. You will get to see a lot of obstruction relevant questions. So history of surgery and the vomiting. So we suspect small obstruction, large lobe and air fluid level. Okay. Now, in case of paralytic ileus, why it's not the vomiting thing is a contradicting here. So we are not expecting this type of vomiting in paralytic ileus. Normally, after a surgery, if the bowel sound has not passed, that can be the main complaint. Okay, and some cases, patient usually have a diffuse dilatation actually. Okay, so here is a dilated loop, whereas paralytic ileus has a diffuse dilatation. It's not like a loop, Riaz, like a diffuse actually. Okay, is that clear to all the doctors? I hope that's a yes. Reference, I mean, you can go to RSCGP and type acute abdominal pain in elderly. Um, so you will find lots of differentials like this. Not only this one, you will find obstructed hernia as a differential obstruction, because in elderly group, the hernia and obstruction, it can be a differential. So keep that one in mind. Don't forget to read this particular reference. I hope that's clear. All right. Why not large bowel? Already mentioned why it's not actually, because it's the history of that surgery goes more towards that actually. And also depends on the CT scan will be also a point actually. Now, here we go. Like, will help you more. In this is a small bowel obstruction, so you can see the small bowel obstruction. Addition after the post surgery is the clue or the key. All right, so you need to be like a mindful in the exam why this is your answer actually. In the other cases of the large bowel obstruction, CT scan, the findings would be more in the peripheral sides. Okay, so that depends on the CT scan, and there will be some other histories like colon cancer history, volvulus history. Those type of history will be more evident actually. High pitch bowel sound can be present in both cases, but that's not given in this case. Some cases they give you a scenario and they'll ask you about the management. Based on the small bowel, based on large bowel, you will pick up the managements actually. All right. Now here is the thing. If it's a small bowel, we are expecting this type of CT scan is given. See, these are recalls, so sometimes the exact CT scan, of course, no one can bring from the exam hall. So they can assume, they can guess actually. So here it was mentioned like some of the loop that is affected, multiple loops are dilated like that. So that's going more towards the small bowel, but depends on the cell. And if you see the large bowel, large, you see, it's quite large compared to this one. So that's the large ball. So it depends again on the CT scan actually, right? It is possible you can be given X-ray. So small bowel will be more in the peripheral obstruction, whereas large bowel more in the small bowel would be more in the central, whereas large bowel more in the peripheral. I mean to say, if it's this is the abdomen, small bowel more in the central, whereas large bowel more in the peripheral sets. Here are certain things about the intestinal obstruction. My job is not to tell you this is answer, this, that, but why my classes are popular because I also keep explaining that what type of relevant topic can be tested. Now, in terms of small bowel, large bowel obstruction, I'm telling all the things from the last 5, 7 years, which is very popular. So one, this differences in small bowel, large bowel is very, very important because often we got stuck. Is it a small bowel or is it a large bowel? So this particular one helps you actually in this case, especially small bowel obstruction. This is one of the fantastic point, the addition one actually. All right. So clinical feature, of course, most of the cases there'll be abdominal distension, nothing going out. These will be some of the key points actually. Also, we do check the vital things, vital assessment. Now, based on that one, we also set the treatment protocol because if vitally deteriorating, we probably don't have that much time for going for a CT scan. Am I right, guys? Like if vital is deteriorating, we may not have that enough time to go for CT scan. We can do a simple X-ray and we can get the clue and take the patient for the surgery. Or in the emergency room, there is a emergency ultrasound is available, which is the first ultrasound, and we can take the patient for the surgery. If radiology is given in your question in MC, it will be easy for you to make a right judgment actually. Okay, so small bowel and large bowel obstruction radiology must, which we have just now seen here. So small bowel, and this is again the large bowel actually. Okay, yes, CT scan is kind of confirmatory, my dear. All right. There's another topic sometimes that comes actually, intestinal pseudo obstruction. Have you heard about this situation? It also has another name. Sometimes they use the synonym. So intestinal pseudo obstruction. It's also known as Ogilvy syndrome. Ogilvy syndrome, actually. So in that case, how do we understand? They'll give you again a X-ray, and where the cecal size will be more dilated. So it's more like a coffee bean, or the cecal size is dilated, and they will give you few things like old age, home care, or things like that, and constipation for long day. So old age, home care, constipation for long day, and the radiology is showing, a large cecum, surely indicating intestinal pseudo obstruction. Now, which brings us to another emergency point of summarizing all the obstructions, pseudo obstruction, herniations, um, emergency X-lab. Now, one thing we learned that if vitally unstable, I mean, you have to go for surgery at any cost. There's some other condition. If you see those signs, you are taking the patient for surgery. Can you give me some clues in the comment section? All one mentioned that vitally unstable, but what else? Now, another thing, if you see any free gas under the diaphragm, I repeat, if you see any free gas under the diaphragm, which is also not a good sign. So you're taking the patient for the surgery. Then the cecal size. If the cecal size is more than 13 centimeter, that's another big red flag. Okay. So this kind of points, if it is present, uh, we take the patient for emergency lap chole or open. That's one of the things. And last but not the least, you will get a lot of questions regarding the small bowel and the large bowel obstruction related management. So from this part, you can also learn the management. This is given in our SMA notes. So NGT compression, surgeries, whereas enema in the large bowel. Okay, and again, you can see surgery or rectal flatus tube. So these are some of the points. So can be asked. They'll give you a clue. Say if it's small bowel obstruction, then they're asking what's next. You try for the NG decompression. Small bowel obstruction, what's next? NG decompression. This is how the question will ask you. Last but not the least point, there will be another obstructing thing from the pediatrics. A lot of thing can be, but among them, Hirschsprung is popular. Hirschsprung, you know, no pass, like like newborn unable to pass the meconium of the stool, and this is happening for the 2 days, no stool. If you do the digital rectal examination, pararectal examination, nothing will come out. Okay, so for 2 days there will be nothing, but from the fourth day, probably little leakage, because it's not absolute obstruction. It's just a no peristalsis there. So when you are putting too much into the baby, a few things started to get leaked actually in Hirschsprung. So Hirschsprung comes with like a fourth day. If they mention, they might tell you there was unable to pass a stool, and now spurious diarrhea. This is that a original diarrhea? No, it's like a spurious actually, because it's like a leaking diarrhea. It's like because of pressure, little leaking. All right, so say spurious diarrhea or a little leakage. They will be mentioning for the Hirschsprung. Actually, this is a whole different disease. We don't have that time to discuss Hirschsprung now, but surely it comes in exam a lot. Last but not the least, the intussusception, red currant jelly stool. This term is given. Think about the, yeah. Are we clear about the obstruction, guys? I mean, I took a little time, but you see one particular question. This is one we solved, but another probably four, five we learned. All right, happy with that one. We can move forward shortly to the next one. 28-year female presents with the primary infertility. Now, reports having regular menstrual cycle. Laparoscopy is confirmed. Image is given here. What's the likely diagnosis? Yes, please. You have 10 seconds. In the main exam, you'll not get that amount of time, guys. But like you have to read the question which I'm reading, and then very few seconds to answer. Now let's go and further explore this question. Tubal obstruction we have chosen. Okay, so we have chosen tubal obstruction. Most likely diagnosis tubal obstruction for the primary infertility. Fallopian tube obstruction or fallopian tube, one of the major cause of female infertility, which is known as the tubal obstruction. It's a more statistical question. It's nothing really a science, or it's like a more statistical question. Like for a female infertility, tubal obstruction or fallopian tube obstruction was the primary, cause for causing this infertility. So tubal obstruction, yes. Further required laparoscopy will be required to rule out is it a tubal obstruction or endometriosis or a scar tissue causing it, ruling out by a laparoscopy. Commonest area, fallopian tube obstruction, commonest cause of infertility. Next one, patient with a history of Barrett's 24 months ago with no dysplasia. Z8 is already controlled on PPI, now shows high-grade dysplasia but no esophagitis. Please mark this word high-grade dysplasia. What is the most effective approach? They keep changing line. Sometimes they ask initial, sometimes they ask most effective, sometimes they ask best. Most effective is kind of like a best, something they wanted to know. Now, in this case, most effective, it's a clue as well. Like many questions, if you see what is the most effective, which is the best, and surgery is offered, often that is actually the best, actually. All right. So here the answer is a most effective is a surgery. Most effective would be surgery. All right. Going to next one, it looks like more like a psychiatric question coming up. 35-year male presents with a belief that he must save people from aliens. By the way, we don't have any report of aliens till date. I mean, so aliens, when someone is telling, maybe surely the person is having delusion, hallucination, whatever. After watching a TV show called Omega, believes the word Omega was a hint, but immediate death of people, she feels parallel to intervene. Okay. What type of delusion the patient is experiencing? That means after watching a TV, they start feeling the same. I think sometimes it also happens with us. Like when you see a very good TV series, we start thinking ourselves into the situations and something like that. Yeah. So in that case, what we're going to, it's a referential delusion. I repeat, it's a referential delusion. Like what is referential delusion? Let me highlight here for you this referential delusion. So referential delusion is belief that neutral stimuli like TV shows, songs. Is it possible that guys? I mean, I'm not sure about the others. For me, sometimes when I hear certain songs, it took me to that particular time. Okay, I mean, okay, 10 years back, I used to listen to that song, and I was probably in that place. I was traveling to that place. That time, that particular song was released. Or maybe some people think like a relation and things like that. So songs, things, this kind of thing. Referential delusion, actually, it is called, actually. I'm right. So, anyways, referential deletion, but there's some other types of deletion available. You can see persecutory deletion, believe others are trying to harm him. This is persecutory deletion. Grandiose, like they feel they like a superpower, they start feeling like they're Hulk. All right, so grandiosity, deletion of grandiosity, religious deletion actually. All right, which is not uncommon. There is we see a lot of extremists as well actually. All right. So, because of extremist things, a lot of people sacrifice and thinking that. So they took things in a different way, actually. Let's not get there. And somatic deletion, belief about the body function and sensation, actually. So a lot of type of deletion is available. Great. All right. Because the person is actually watching a TV, from that the person is thinking. That's why it's delusion. If there was nothing like that, and then they were thinking, okay, that he's just sitting and something is coming up in his mind. In that case, you could think about the hallucination. Actually, I hope that's clear. Delusional. You see something, I mean, in the TV, and you start imagining in that way. Um, I mean, that way it's logical. I mean, the word logic is for the delusion. Whereas the hallucination, the word illogical we put actually. Okay. Whenever in the question next time you see, try to imagine and think, could it be logical? If you can relate the logic, somehow it's delusion actually. Because watching the TV and then you are putting you in that spot, maybe it's delusional. Yeah. All right. If not, the TV is present, you are just imagining the aliens are coming, this, that. Now it's hallucination. Is it clear to everyone now? I hope this clear. This will help you really. Like this logic or illogic. Right. All right. So last question was differential delusion, persecutory, lot others. We're going for the next one actually. Okay. Delusion has can be of lot of bizarre, non-bizarre, many things out there. Okay. Moving to the next one. I think this one we solved actually. I mean, yeah, this one is the new question. 30-year-old female planning to travel to a country where hookworm infestation is endemic. What is the most appropriate precaution you can take? I think it's loud and clear. It's loud and clear. You can't walk in a barefoot when you go there, actually. Right? Remember in the parasitology classes we used to learn Ascaris lumbricoides. Right. So there's no another one. I forgot the name. Nicator, I think American Ascaris lumbricoides, Nicator americanus. Yeah, so many names out there. Some of them has this type of tooth. Some has two, like four, six. Okay. Anyway, so many things. I don't know what was the benefit. of learning about the parasites. Okay. So avoid walking in a barefoot. That's the most important thing. Next, old men with a mild dementia in a hospice come for sildenafil prescription. Um, as is in a relationship with the family member of the other hospice patient, what to do in that case? Would you like to give the sildenafil, what is known as the Viagra? Mentioned as a mild dementia, should we first go and start um assessing the capacity, or should we talk to the hospice service first? Like if the person is from that service, we heard that the person relation now he came for. Now that's a little bit tricky. So in this one, this is little controversial in between option two and option three actually. So this one we choose like talk to the hospice service. All right. So hospice is a program that gives special care to the people who are near to end of the life and have stopped uh, treatment to care and control their diseases. Hospice offers, you know, physical, emotional, spiritual support to the patient and their family. So it's like a service-based thing. It's like I said, it's not a hospital by the way. It's a service-based thing actually, like a retreat center or something. So if someone like it's more like a ending their life in that way, the last few days with pleasure and this that. So that's one of the point. I think we want to go with talk to the hospice service. Are they really in relationship? What's the situation out there? So you should at least ask once actually. For the patients with dementia, patients with this that, there is always there's some institution the services. So you can talk to those institutions. Yeah. First, talk to the hospice service, then go with the C. That's my opinion. First, talk to the hospice service first, actually. Okay. As I said, a little controversial, but I would prefer talk to that service first and then assess the capacity of the patient. I already mentioned mild dementia. Now, if you see this one, a patient with mild, so if a patient with mild dementia, so you have that point actually. It's not like a patient with a severe dementia. Okay. Right. Next one is a 45-year-old patient with a blood pressure reading of 145 by 90 into separate occasion. So it means the person probably having hypertension. Anyways, the patient has no family history of hypertension, routine examination showing this, all are normal. What is the appropriate investigation in that case? Yes, go ahead, guys. Interestingly, uh, some people could be with the C, but I think the right answer is 10. According to Australian guidelines, I repeat, according to some of these Australian guidelines, thyroid hormone test can help identify hypo and hyper because you'll see the thyroid related, there are provision of blood pressure thing was mentioned. Both can attribute to elevated blood pressure actually. So you need to check the thyroid function. And this is also common in our practice. Those of you who are practicing regularly must be knowing in hypertension and this that cases, if we can't make a diagnosis directly, we check out the cortisol level, thyroid level, and all these things actually to rule out the secondary causes. Right. So this is surely A is the answer in this case. Ruling out the secondary hypertension, ruling out the secondary cause of the hypertension, secondary hypertension, some other causes. So Cushing, hyperaldosteronism, coarctation, pheochromo, and stenosis. Next question. 34-year-old male presents to the Korea and unstable kid. Her father and auntie died in young. Similar symptom. What is the next step in the diagnosis? Now, this one is easy. First of all, what is the diagnosis? The diagnosis will be thinking, yes, please. So it's Huntington's. Well done. So Korea and the family history. Korea, instability, and the family history. So this is going more towards the Huntington's. So what we can do, go for a genetic testing. So Huntington's and genetic testing, very popular in the exam. Very, very popular in the exam. All right. So Korea Gate, this also has mentioned about the family tree. So it's autosomal dominant thing here. Already Korean Gate is mentioned. So positive family history, right? So what you can do is a genetic testing here. A little bit more slides and references. So most accurate test would be genetic testing. They have some behavioral changes and they have some movement changes actually. Some clinical features of Huntington. This slide you can see after the class. So not a problem. Yeah. Autosomal dominant again. Yeah, no problem. Okay, next one. I hope we are ready. Okay, 30-year-old woman presents with a 12-month of irritability and she had appendicitis 12 years ago, remaining showing. Now, what do you think? I think we do have a similar one, appendicectomy previously. So this issue can be now because of the that previous surgery following this adhesion. That's it can be responsible for the infertility. I'm sure you, when you read the causes of infertility, you must have find that one if there is any previous surgery that can attribute to infertility. Okay. So post appendicectomy and leading to pelvic adhesions actually. Now, how it can be caused? Adhesion can cause the mechanical infertility by restricting the mobility. The patents of the fallopian tube still may be patent, but still the chances of infertility would be higher. So pelvic adhesion, and surely this kind of situation will gradually leading you to infertility. Okay, next one. A 12-week pregnant comes for a regular visit. What is the additional test you want to add here? 12 weeks pregnant coming for a regular visit. Some with cytomegalovirus. Any reason for that one? I mean, in the beginning. Regular checkup. It's a A, I think. I mean, why I should go for a cytomegalo and why I should go for a HPV testing? For a pregnant who comes for, I think I would love to check the vitamin D level, iron level, this thing. Regular antenatal visit. Come on, guys. Okay. So just give me a All right, everyone. So this is like a antenatal visit. So for a basic antenatal visit, vitamin D is the. I mean, in order to uh, go for cytomegalovirus, you need to have features of cytomegalovirus. In order to have like HPV DNA testing, like a or the PAP testing, you need to have certain thing. Like if they're mentioning there was no PAP done in past, or if you see that there is a ward or something like that, then you can consider going for those tests actually. Vitamin D, that's like the basic, and definitely, you know, is important to rule out actually. Okay, great. Next, Graves' disease. You must be knowing of the Graves, like thyrotoxicosis, one of the main causes, like a Graves. How will you confirm the diagnosis? How will you confirm the diagnosis? Now, in the Graves cases, which is stimulating autoantibody produce, please remember what's the mechanism of Graves. So the mechanism for development of Graves is a thyroid autoantibody. I mean, stimulating, not inhibiting. Inhibiting autoantibody produced in Hashimoto's, stimulating autoantibodies produced in case of Graves, actually. Now, but they're asking for confirmation. So, initial is a thyroid function test. I hope so you're getting me. If it is asked for Graves' disease, what is the initial test? If they would have asked initial test, then definitely thyroid function test. Now, they're asking now, what's the confirmatory? The confirmatory test would be this autoantibody test actually. So confirmatory is here, this autoantibodies. Autoantibodies. No doubt. This is a loud and clear question. Right, guys? I think most of you also I can see answered it quite correctly. Now I'll ask you a separate one here. If this question is about thyroid mass, then what you gonna do for this one? Thyroid function test, thyroid ultrasound, biopsy, scan, whatever. Now, if this is a mass, what as an initial you'd like to do, and what as a confirmatory you'd like to do, this is another popular question in the exam. Now, let's start with the initial. So, initial, many are saying this is ultrasound. That's a wrong answer again. So, initial for even for the thyroid mass, it's a thyroid function test. Thyroid function test is the initial. Let me show you. That's why I asked this cross question. I mean, because I saw this time it's an easy one that came, but I need to check with you the tough one here. Let me show it to you guys. One second. Yeah. So I do have two references. One for that thyroid nodule or thyroid mass, kind of same thing. So here we go to see. Okay. So one, the right hand side is the John Muttak one, and left hand side is the RSCGP one, actually. All right. Now, because of that, you can get confused about the. Yes, for the thyroid nodule and this that particular, one of the mainstay is we go for ultrasound. But if you see that eventually what is the line of testing things are not always given in John Muttak. Please need to be careful. They don't mention about your initial, I mean, so this is a focused, because this is a book for the GP, so they might not tell you what's initial and this that, so they'll tell you the specific one. So for the nodule, of course, we need the ultrasound. Any cyst nodule, these things we need ultrasound. Some cases later we might need MRI for some cyst. In these cases we don't need the MRI. That initially you go through this ultrasound and this that, later you might need the FNAC thing because it's a mass growth, it can be a cancer. But whatever it is, like you see according to RSCGP, or in if you see our SMA note as well, so any mass, any nodule, anything, it's a thyroid function test. Based on the thyroid function test, we decide whether go for ultrasound, whether go for a FNAC. Is it clear to everyone now for this one? I'm sure it is. Very important, guys. Very important. Do not miss this one. Please answer it correctly. Okay, I'll be adding this one. Okay, clear everyone? This one is also important, guys. So it means you need to learn like the primary hypothyroidism, secondary hypothyroidism, and subclinical. Is these things are clear, or do you want me to explain it actually? Primary, secondary, and subclinical. Often questions are tested from this particular section. Is this thing is clear to the dear doctors? We'll see. I mean, if more people mentioned about it, it's not clear, then I can. Okay, I'll see. Let's. Apparently, looks like. Okay, starting with this one, primary. Okay, let me show you first. First of all, primary. Now, what is the basic test for thyroid? Thyroid, the basic test is thyroid function test. And among the thyroid function test, is it a T3, T4, and the TSH? Which one is the main one? TSH is the main one. This is the basic. TSH is the main test. Also, we look up to the T3, T4 together actually. So for primary hypothyroid example is related to the gland problem, not a pituitary problem or other problem. So primary problem is always related to the gland. Now, if we talk about the primary problem, so for the primary problem, so TSH is this line, T3, T4 is this particular line. So for the primary, are we expecting T3, T4 level would be low because it is hypothyroid, T3, T4 low, and at the same time, TSH should be opposite, that is elevated, right? So this is the basic expectation. Primary related to gland. So primary hypo means less. So T3, T4 less, TSH is opposite. Okay, so this is the basic. Everyone, I hope that's clear with the first one. That's everyone clear with the first one. Now coming to the secondary hypothyroidism, how it is different from the primaries. Now, secondary, it can be because of pituitary, for example. Now, the same thing we are expecting T3, T4 low because it is hypo. T3, T4 low expectation. Now, TSH to be elevated normally, right? Because it's hypo. But here, because it is a secondary, your TSH, which is one of the main parameter, stays normal rather than elevated. Is it clear now, everyone? So, in secondary hypothyroidism, TSH level is like flat line or normal, okay, which was supposed to be elevated. So, this is one of the differentiating point for secondary hypothyroidism. Then the last one, which is one of the very popular and common one, subclinical hypothyroidism. Now, in subclinical hypothyroidism, you will see TSH is elevated because it is hypothyroidism, but whereas T3, T4 stays flat or normal. All right, so that's the subclinical. Did you manage to see the differences secondary and subclinical? In secondary, you can see the TSH not elevated. TSH is not affected in secondary, whereas in subclinical, TSH, it is as usual affected. You can see the difference. And primary is primary, T3, T4 low, and TSH elevated. Are we clear with the differences, guys? You need to write it in practice. Otherwise, you cannot remember this, guys. Unless you are already a practicing doctor and you are practicing this one regularly, which is different. Otherwise, if it's new to you, you need to write it by practice. Otherwise, you will mess up. Okay, at least remember one. Like say primary, both of them are T3, T4 decrease, TSH elevated. Gone, done. Because it's primary. Now, difference and the problem between secondary and subclinical. In secondary, the TSH, secondary TSH because it's pituitary, TSH main parameter remains normal. Whereas in subclinical TSH as usual affected. I hope that's clear to all of you. Great. Next one. 22-year state level swimmer. I mean, if you go to Australia, a lot of questions will be made from the swimmer, surfer. These are very common. Sports related questions can be very common. You need to also study about the sportsman when you become a doctor in Australia, because a lot of people will come to visit the GP and they will be a sports person. So they might have a lot of like a skin, orthopedic and those problems. But you as a doctor, you as a GP, you need to know most of those things. Okay, state level swimmer presents with itchy, dry, and sole, this, that. In between two toes, this problem lesion is persisting for few weeks, has not improved with basic moisturizing. Now we try this thing, anything happened to the skin, we try with moisturizing. What is the appropriate management for this condition? Now, what is this condition is about? So this is nothing but a typical, because they're going into the water all the time. So very high chances, there's a possibility of fungal infection. Am I right? Very high possibility of fungal infection in case of the swimmers. Yes. So in that case, what we can do is a topical antifungal cream. So it's a tinea pedis. Tinea pedis, topical antifungal cream for the tinea pedis. Also calls this thing also sometimes called athlete's foot. Maybe you heard this thing in MBBS, athlete's foot. Yeah, great. Here's a little nutshell which I added for the new batch classes. Now, history of surgery. Yeah. Okay, so like a reference of the previous one of the infertility. That's okay. Yeah, that came up somehow. That's okay. So athlete's foot. So athlete's foot. Yeah. So antifungal. And the previous one's one of the reference, history of surgery, and adhesion can be reason. You can go for laparoscopic for diagnosing. Okay. 82-year-old woman living in an aged care or old care home, it is often called, with the agitated and disoriented in last 3 days. On examination, you notice several bruises on her upper arm. What is the most likely cause of her symptom? Not a difficult one. First of all, it can be UTI, isn't it? Old age, confusion, UTI, until proven otherwise. But do we have any special clue? Yes, we do have bruises. Normally, it can be UTI, but in this case, we have bruises. So that is a, you notice bruises in the upper arm. Okay, someone may be trying to. So this is elderly abuse. So elderly abuse can be in many ways: physical abuse, financial, emotional. Emotional one is one of the dangerous one. They don't expect much except for care. So that's one of the things. Restraint will not bring bruises. Clear? Okay. Next one. A 10-year-old Syrian boy presents to the GP practice with a 3 months old history of cough, hemoptysis, weight loss, and a chest x-ray. Based on these things, which are following is the most likely diagnosis. Now, this one is easy because keyword is this is an immigrant, right? So this one is an, first of all, what is it? This is an immigrant. So if it's an immigrant and yeah, and there's a history of cough, hemoptysis, weight loss, very classic feature for tuberculosis. Very, very classic for the tuberculosis, actually. Tuberculosis. Yep. Everyone answered correctly. All right. So chronic cough, hemoptysis, weight loss, we think about the tuberculosis, and is this outside Australia immigrant? So this is again TB. Now, one of the tests before you go to Australia is one of the mandatory tests. Those of you who have been to Australia, did you guys all go through the tuberculosis test? I mean, the chest X-ray from a authorized institution. I think I'm sure you did. Some cases, there could be urine test and this that depends on age group and this that. But TB test is mandatory. Even if you want to, um, increase your visa and this, that, still, you probably need again a recheck. That's the thing. Yeah. So chest X-ray is a must thing, but other things if they suspect something. All right. Next is a maculopapular. Yeah. Maculopapular rash, and sister was unwell 2 weeks ago. So what is the management? You can see, please focus on this picture. I'll be zooming this picture for you. Yes. So in between the finger, if there is a lesion and it's itchy, so in that case, maybe an household family members affected. My diagnosis here, scabies. Okay, scabies. So in scabies cases, what we do is a permethrin. Can anyone tell me what is the percentage of permethrin we use? What is the percentage of permethrin we use? We use the 5% permethrin. Who can tell me 1% permethrin we can use in which cases? This is another. In that case, lice. 1%. ADD, it can be eczema, but anyways, uh, yeah. One thing about eczema, is it contagious? Not really. It's not contagious actually. Yeah. So again, in a nutshell, so maculopapular, try to know about the types. So maculopapular, sister annual for 2 weeks, think about scabies because family member affected. So first line of treatment for scabies is a permethrin cream. Can you tell me another second line treatment, guys, for scabies other than the permethrin? We can reapply the permethrin. So we have seen also question in MC in past that permethrin is given, not working, what's next? Again, reapplying permethrin. But I want to know alternative. So alternative, what are those? Permethrin, not working, patient is coming to the doctor. We ask them continue permethrin. Now, if somehow if it is not working, anything second line we can give. Okay, there's a benzyl benzoate thing, but in terms of efficacy, is it more effective than permethrin? The quick question is benzyl benzoate, is it more effective? Unless if you have some rash issues with permethrin, we actually don't need the benzyl benzoate. It's an old treatment. The permethrin is a new, not really new, but it's been for 20 years. So permethrin is still. Now, if you need like a more powerful one, like say there was a long back a question, it was too much affected. The previous picture you saw is like this, but if the whole body is affected, there is a term called for that kind of scabies. It's called Norwegian scabies. Actually, the person looks quite, scary. So in that case, what type of treatment are you gonna give? So answer is a ivermectin. Okay. So extreme severe cases or Norwegian scabies cases, we can use ivermectin. We also found that ivermectin was used in COVID days. Did you remember? I think some of you also used it. So the initial treatment of ivermectin, I mean, during COVID days, I mean, I think all type of heavy treatments were used in COVID, and all type of researches has been done. Anyways, some bad days actually. Many of us lost, I think, someone or someone get affected because of COVID. Okay. This one was a new type. I mean, normally when I take the lot of theory classes, I mean, all relevant topic I highlighted. For example, when I was telling about the gout in the theory classes, I was telling about their managements and this, that, whatever that has been tested in the exam. But this is one new thing, a bit new thing came up actually. I was also not fully sure about this question when I saw that one. So I have to also search for this question. So before starting allopurinol, which is a treatment for what? Treatment for chronic gout. Chronic gout. Okay, so what test you like to do? It's a tricky one, guys. Okay, let's see and try to find out. I could be wrong. Okay. I picked up this one as a TPMT. It's a new topic, doubtful. I can be wrong, by the way. Let me tell you first. Before starting, alipidinol. Okay, so this is one thing. HLA. Now, recent one of the update is HLA. This particular testing actually, right? So I think these are some of the things which we found. Uh, Still, as I said, this is under process. I'm also trying to search and learn about this one. Let's find out what are these tests are. Now, TPMT is a blood test, basically. Check the genetic variation, identify risk of the side effect of some of the drugs. Okay, so this is one of them. And another one, before giving allopurinol, I think it's better, you know, we go through like, HLA-B50. But as I mentioned, identifies patients at risk of severe reaction, especially Asian population, right? So three is probably we're not getting into. So it's between one and the two. So honestly, I found references of both of them in some places. So I'm trying to figure out. So this is the only question today I have a little doubt because it's a little bit new topic. So I want you guys to have a look by yourself. I'll create an inquiry zone for our doctors so that we can come up to a point to discuss this kind of trendy thing. So in this case, actually, initially I found TPMT was the answer. Later, I also found another reference with a this one that HLA B 580 is also correct. So what I'm looking forward, guys, I mean, because when you search in the internet, we found a lot of things, and but usually what how I try to confirm things by getting things from any textbook. So if anyone here found anything from the textbook regarding this thing, do let me know or do let us know in that inquiry zone. Okay, so that's the thing. Mm. So look forward, guys. So it can be one, it can be two, but we look forward to this one. Right. All right, guys. Okay, someone has a nice one mentioning according to RSCGP, okay, HLAP. Okay. If by the RSCGP, it would be really nice. And if you do have a reference or any screenshot, please do also let us know. Actually, it will be helpful. Okay, someone has this thing, maybe directly post it. Just taking a second, guys. All right. So look into the RSCGP for this one again. I'll get back to you on this one maybe after some time. So till then, I think we'll be thinking as a two as correct, but have to look into the reference from authentic books or like RSCGPs or this that. Okay. If anyone has any screenshot or something in between classes, you can also share about it. Okay. Together we have a lot of brains, so can work together actually. Okay. So one of the areas where I got stuck was this one. Yeah, I also think so. TPMT is more for the azothioprine. That's why I think HLA1. A nice question, by the way. This picture I took from the master of the board. You'll get to see a lot of questions regarding the gout, especially acute gout treatments as painkiller and also giving indomethacin. which is popular. So, like you can see NSAIDs, like a indomethacin, often a choice over colchicine. Some cases, in acute cases, low dose colchi is also offered. Also, please note with colchicine, it can leads to diarrhea. That's also a popular AMC question. So far we have found indomethacin. So far we found low dose colchicine as treatment. So far we have found also steroid as treatment. Steroid can be as a treatment when there is a renal impairment, correct? When you cannot use the NSAID, in that case we can use the corticosteroid actually. If it is mentioned, I mean, they don't offer steroid or the patient has issues like Cushing, in that case you can go for, yeah, in that case you can go for low dose colchicine. Okay, someone has a line. Okay, that's I think nice. I think maybe a good reference. Thank you, doctor, for sharing. Is this one from the RSCGP, doctor? Is this one from the RSCGP one? Okay, like from RCPA. Okay, RCPA. Thank you, my dear. Another doctor shared another one. RCPA. Okay. Okay. This one is better. A genetic test is recommended. Prescribing initial allopurinol. HLA. Okay. So we were correct in some way. I didn't have the right reference. So let me add that one in that slide for you. Just take a second. Okay. So we have added that one by taking your help. So thank you. Okay. We can start the next one. Okay. Deep cut into index finger and no bone, nerve vessel has been damaged. Which anesthetic will you use in that case? So for this one is a bit straightforward, I think. Point 0.5. Yes, digital block. So says there's three main findings. It's a more like straightforward question. I mean, not that conceptual actually. A little bit more. Bupivacaine finger block. Yeah, have a look. Pain blocks last 15 hours. Yeah. Whereas epinephrine adds only 1.5 hours to pain relief. Okay, so that's why um, we're not using the adrenaline or epinephrine one. Other than this, digital blocks are more better. Mhm. Next one, doctors. Okay, please check the question. It's Aboriginal related. So, Aboriginal child brings to the clinic. It's unclear what vaccination previously received or their extract age. To ensure the child is up to date with the immunizations, which of the following vaccine should be prioritized as a part of catch-up vaccination schedule? A, according to Australian guidelines. Which one should be added as a prioritized catch-up? So, of course, the deadly one should be considered as a catch-up. So, definitely meningococcal vaccine. Meningococcal is the dangerous one. Someone asked about the previous slide. Yes, overopen finger block finds more longer hours. Okay. All right. There's a book actually. I mean, you will find Australian Immunization Handbook. There is something. You can have a look. Certain this type of vaccination, then catch up vaccinations, some relation with vaccine and some other diseases like egg allergy. Yeah, some this type of questions also asked actually. Okay. Anyone remembers that question? Like, MMR, is there any relation between MMR and egg allergies, guys? The popular question. I haven't seen this question coming for 2 years, but I've seen it in past. It was very used to be very common, like common question. So the question was, is there any relation between the MMR vaccine and the allergies or egg allergies? The answer is technically no. Right? There's nothing like that. It was a misconception among the people actually. Again, the vaccine you cannot force. As a lot of parents still out there in Australia, um, they're not giving their kids vaccines, thinking that vaccines are harmful actually. All right. I think we have seen enough during the COVID time, right? Like, I'm sure everyone knows someone, I mean, who was not taking the COVID vaccine. And those people still claim, I mean, blame or claim these days. I mean, those people took vaccine or those people was confused and now given vaccine, there is certain sort of dementia. I'm not very sure. I haven't studied that topic very well, but a lot of people also mention about forgetfulness or this kind of thing. I think as a COVID vaccine or post-COVID complication actually. So COVID related everything is under a bit controversy. I guess it was a very big thing, honestly in general actually. Anyways, we have passed through that part. Deadly one actually. We don't want to remember. Next, DDH with a 18 months. What is the most appropriate in this case? It reaches 18 months, not the initial 6 months. So that means what? Surely not harness, I guess. Developmental dysplasia of the hip, 18 months. So John Murtagh, if you check the John Murtagh 8th edition, in that case, 0 to 6 months. This is exactly reference taken from John Murtagh. Sometimes John Murtagh we call John Baba. Anyways, so 0 to 6 months, public harness, 3 to 18. I mean, in between 3 months to 18. Yeah, spica. You can see this part, spica. And 18 or more than 18, open reduction, open surgery. So coming back to this question, what is your final answer? Surgery, open reduction. Anyways, this is a very classic one. Very, very helpful and useful, well, like developmental dysplasia of the hip. Okay, so this one definitely, uh, at the time of discharge of a newborn, they try to do the test, autonomous Barlow test, and clunk sound. So in that case, a confirmation, like even clinically, that is developmental dysplasia of the hip. And later on, when the child started to walk, there will be limping. The common term is limping kids. Transient and Perthes are sharing the same age group, but transient synovitis has a history of, you know, upper respiratory infection, whereas Perthes has a positive P for positive, X-ray finding. Often, a spatial line, please note and take note from a spatial line, increased density of the femoral head. I still remember a lot of question on that one. They didn't give you the X-ray, but they were mentioning increased density of the femoral head or X-ray given, also mentioning the finding, increased density of the femoral head. This goes with the Perthes. Please note, transient and Perthes sharing the same age group 4 to 8. And the popular one, sleep capital femoral epiphysis. There was a popular question. A child is crying because the ice cream is dropping from its cone. I think in the theory batches I've shown that picture. So sleep capital femoral epiphysis, you can see that one in the X-ray. Okay, the ball of the acetabulum and the femur, that thing is separated. Okay, so sleep capital femoral epiphysis. And last but not the least, fever and unilateral joint pain, fever suspected, septic until proven otherwise. Give a shot of flucloxacillin in that case. Give a shot of flucloxacillin in that case. All right. Next one. Obesity in a lady, BMI 42, surely obese. Now, which one do you recommend? Is a sleeve bypass ballooning. Uh, Bypass is the bigger surgery, no doubt. But why sleeve in that case? Now I picked up also sleeve. There's reasons some behind that. One so popular weight loss surgeries nowadays. Now why not gastric bypass? Why we're going with the sleeve in that case? Gastric sleeve surgery. Now you can see which portion has been, yeah, the sleeve surgery. Bypass, it's been this part cut, and this part conjoint like that. So in the sleeve surgeries, now what do you think? The reason behind that one is like the safety level and the side effects are less with the sleeve surgeries. Clear, everyone? So the side effects and these things and will be less in the sleeve surgeries. All right, guys. Okay. Next one. A child at the school. I think we'll go for a break shortly. Doesn't play with the children, always left alone, no eye contact properly, incomprehensive. I think that's the easy peasy one of the question. We can go very fast. The answer, not communicating well. This is nothing but autism spectrum. Autism spectrum. Okay, there can be a lot of words. Autism spectrum. Under the autism spectrum, other conditions can came among the autism spectrum. Typical autism, which can be tested in exam. Then there can be rates and there can be Asperger's. Okay, so all these can be tested in exam. Actually, autism came in past, Asperger's came into reads. I haven't seen in coming in the exam. The autism, this is the classic autism cases actually. So usually I say verbal and non-verbal. Now, verbal means communication, understanding, level of skills. Non-verbal means even tricky. Non-verbal means like by eye contact, you are understanding someone, by hug, by kiss, like emotion expression. That's the non-verbal. So in autism cases, honestly, the verbal, non-verbal, both are affected. Do you agree? Yes. You can get to see a lot of people, I mean, working in a lot of restaurants in Australia. I found one in McDonald's and one in a coffee shop as well. Two, three times I found. So the person is autistic, but they have minimal skill, and the coffee shop is allowing him with proper induction training. Okay, so it's like nice actually to see. Now, Asperger's is again verbal and non-verbal. If you see, in this case, actually, only non-verbal is affected. Only verbally, it's fine. Now, if you have seen that famous drama series like the Good Doctor I'm talking about, the Sean Murphy character, I mean, so he's having these issues with Asperger's actually, where he cannot communicate, he does not understand sarcasm. Yeah. But his other communications, actually, verbal, motor skills, and others, those are fine. Those are fine. So, yeah, that's kind of like that. So, it's kind of like Asperger's, actually. All right. So, but nonverbal is affected. He cannot counsel a patient and always someone is coming with him, right? So that's less. You can take an example. So they can be genius, but at the same time, certain skills not out there actually. That's the Asperger's. In case of Reeds, actually, again, verbal, non-verbal, all are affected, but special feature is a stereotype movement, like a repetition of something too much, stereotype, hand rigging again and again. So it's more common in the female kids, actually, Reeds. So these are some of the differentiating point. As I mentioned, autism is popular and Asperger's is also popular in the exam. Okay, great. All right. This one, I think, incorporates in a 6 year incorporates. It means soiling in the pen, soiling. Okay. Teacher at the school noticed and child speech is not sufficiently developed. So what do you think? A lot of you are going with the sexual abuse, but here is the trick. This is autism. Now, why it's one? Why it's not three? Now, if you see, till here in corporosis, it's a sign can be sexual abuse. I agreed on that. Teacher also noticed that. I agreed, but the teacher saw the speech is not sufficient. Like with a 6 year boy, what do you think? The speech is supposed to develop, isn't it? A 6 years speech is supposed to fully develop. Now, is this going under still sexual abuse, or is it going? Should think more about the autism. We'll think more about the autism. Autism. Autism spectrum. Are you looking for a break now, or should I go to two more, guys? Let me know. Two more. Okay. Yeah, two. Okay. 45-year-old presents with the prostate cancer, which is invading the seminal vesicle. So, a lot of parts, I mean, to be considered for a prostate, like first of all, the capsule, then seminal vesicle, then the vertebrae. Lot of stages for a prostate cancer. PS is also important, which is already 55. 55 is quite high. 55 means more than 20. It's quite high. Chances of metastasis means high. Okay. Good news is on the MRI, no direct metastasis has developed because no bone invasion, but seminal vesicle affected. Now, if seminal vesicle affected, what is your answer in that case? It's a very straightforward answer. External beam radiotherapy is the answer. External beam radiotherapy. Now, I'd like to show you for the prostate cancer management and must follow this one for prostate cancer. Now, if it's a stage one and based on the capsule, the Gleason score, so wherever possible, now write like this, wherever possible, or first initial, like up to like a grade two, grade one, two, or two, like that. We try to remove the prostate. We don't want to take any chance. So radical prostatectomy, first choice always, but it has to be below the six, the score. Now, if it's a little spreading, I mean not distant, we call it local spread. Local spread. Now, in terms of local spread means what? Seminal vesicle is a part near to the prostate, seminal vesicle. In that case, what we do is external beam radiotherapy. Now, 3A and the 3BA. So it's like a little metastasis actually, but not like a stage 4 distance metastasis. Now, if it's a distance metastasis, then can you do surgery? No. Can you do external beam radiation therapy? Controversial, maybe not. Now, what you can do here, in these cases, you can do androgen deprivation therapy. Androgen deprivation therapy, like orchidectomy, removing these things. Is it clear, everyone? Stage one, stage two, and stage three. Always check the stages and all these things. Local metastasis, and this one we would say distant metastasis. Local metastasis. I hope that is clear to all of you. Okay, guys. So, guys, let's go for a break now. We'll be coming back after the break. Thank you so much. All right. If you have any inquiries, drop me in my messenger. Info about admission and this that. I'll give you some tips, at the end as well. Thank you. Oh, good news. Okay, we'll go for I think, 8 minutes break. All right, everyone. Are we ready to start? Okay, excellent. Good. Okay. Some doctors, I think, left getting the materials. I think I'll start the process. I think yesterday I sent few, I think it was, and but within 24 hours, there are a lot of admissions. I think so. I'll be sending those materials in cool head tomorrow morning. And after class, of course, I need rest and all this. But I'll start the process actually of sending. All right. Um, Yeah, I'll be sending it anyway tomorrow morning because the admissions within last 24 hours, maybe I couldn't send. Great. No problem. I'll be sending. Yes. I'll be sending in the morning. Yes. Great. Thank you so much. And please let me know one important information that, which month you are targeting your exam, which is like a important information for me, like, which particular month you are thinking for your exam, planning for your exam actually, because different month group people may have a little different strategies actually here. Okay. Now, if you're joining this batch, actually, I'm sure you are targeting maybe June, July. I mean, not before June. I mean, I'm sure like a June, July. But if you're targeting May, maybe you have 1 month left. In that case, and maybe you have to go more through the recorded contents in that case. If you have exam in June, July, August, so probably this batch is quite okay. July, it sounds better actually because we can finish well and we can also take our big mocks and then go for the exam. Mind it, all the candidates will have a exam support group. I mean, exam support group means like during the exam, we also take classes and support you with whatever discussion that new questions, new files that came up, new trendy topic that comes out during the exam. We try to help solve. I mean, we started the trend in any way. So, I mean, a lot of people, I think, in July, so which is good. There will be another recall batch in the month of, I think, 15th of August, I think. I mean, last year we took 15th of August. So I think this year also, I think we'll follow the same. 15th August, we'll have another recall course to targeting the November, actually. All right. And if anyone joins late, this is the routine we are following. And this is for the live 1 year class. And of course, we'll be sending you another 5 years via Google Drive. You can have access to those recordings during the course and also after the course. Now, some people ask how long we can have the access of the materials. Okay, till end of this year, 2025, you have access to our notes, theory notes, record videos as well. Okay, which is a good offer, I think, for many of you actually. Great, and we'll also have the mock test this that, and we'll also have even if you have exam on October, you will also have the support. Actually, support means exam support group. I mean, not any separate charges or something like that. All right, so that's great. And this is like, so this is a very good number. I think it's like a something. I mean, I'm proud of my students. Like, it's a huge number that passed actually. Even last November, I think we had 100, I think 53 passed in just 1 month last November. Anyways, month doesn't matter always, but I think because end of year, so many people goes for the exam to catch the job things in the February. You must be knowing there's two time Australia gives a lot of job. One is a campaigning. It's called JMO campaigning, which starts in the February. So the first campaigning. So December, January, no exam. So most people finish exam by November and try to catch the job things, in February if they have sufficient experience. If they have sufficient experience, okay. So your target after MC Part One would be going for either MC2 or going for a job if you have sufficient experience. Or some people have a misguided idea, they'll go for WBA. See, if you're already not working in Australia, you cannot go for WBA directly. Okay, WBA means workplace based assessment. All right, so that's a different thing. Some people confuse the GP job with a WBA. It's not the same. You need to already get a job offer and start working in Australia. After that, you can switch to WBA program. That's more like MDMS program in our countries actually. So it's like more like a supervised programs with small exams in between. All right. So that's the thing. And another side is the GP route. You need to secure the MC part one and go to the GP route. If you need to have at least more than 5 years of experience to get the GP jobs. Now, if you don't have sufficient experience, can you go to the GP? Yes, still you can. In that case, you need to start working in Australia as a medical officer. You gather more experience, and later you can apply for the GPs. Actually, ultimately, I what I saw, many in Australia they went for GP job at some point, especially female. They went more for the GP because of a bit secure uh, time for working. Like it's more like a 9, 10 to 4, 10 to 5, 9 to 5. It depends actually. Okay. So that's how mostly it is actually. Those of you joined late, this is our comprehensive course access, 1 year plus. I mean, we are doing in live. And of course, I'll be taking classes for a long time. You don't need 9 years, but at least 5 year, another, you are getting via notes, files, many hours videos actually, and also recorded content. We do have a video channels. I mean, we'll give you access on that one where you will find trendy recalls, controversial recalls, radiologies, fundoscopies, and all this relevant. I've been taking classes for a very long time, so I know what probably may have been tested in the exam. So best of luck, actually. Someone asked certain tele observation. Yes, it is possible to get, but after MC part one, it's possible. Depends on getting networks channel. But the main mistake about observership, you when the time you apply, there is no vacancy. That's the major problem. Okay, so they'll tell you, okay, you have to wait. So it's better you apply now. Okay, so if you have an exam at the end, maybe you apply now. At least you enter into the system, and then they will tell you at some point now it's available on vacancy this that. But it's very important. Like if you can walk in to those hospital, you talk to some of the HRs, it's even more better actually. Okay, after February, then there will be the June, July. There's a second round. We call it JMO campaigning, second round, and first round is in February. Okay, so that's the thing. There's two types, and throughout the whole year, some jobs are available in the peripheries and this that. So a lot of types of jobs are available. So it depends on what type of you're looking for. But junior medical officer, JMO means junior medical officers campaigning, where if you have a 1 year, 2 year, or like a very less experience, then these campaignings are very very important for you. All right, I do have a video in my YouTube. So probably I can share that one. Do you want me to share that one? I think, what to do after MC part one. All right. So that video might be helpful for you guys actually to get the idea. Ignore the first 6, 8 minutes because I was congratulating some doctors in that seminar. And yeah, so I'll be sharing that video. It will explain everything you need to know about the what to do after MC part one. I'm sharing that link. Yeah, here. And that videos, yeah, the thumbnail kind of look like this, what to do after MC part one. And I have posted that one. Yes. All right. Our MC part two courses are like available. If you want, you can take it actually. I think a recent offer is going on actually. Anyways, great. And here we go. I mean, this is the in general online. Yeah. So again, summarizing material access we are giving even after the course and exam support groups and this, that, and everything. All right. And a lot of files and things, we have updated recently. So it's helpful. I think it will be nice. We are working more on the files actually. I mean, trying to add the AMC nutshells actually, so that before you go for the finals, so it's like a quick revision, like a flashcards. Yeah, would be helpful for you actually. Okay, this one we will start now. Patient working as a manager in a company with a delay in work studies postponed, and difficulties in organizing um, works with poor concentration all started after an event before 3 months. Asking what you look for to support the diagnosis. This question is a bit incomplete, but let's just see. Okay, a bit incomplete question. Yeah, it's a possibility that The answer is a two. There's a possibility, but still that question I found a bit incomplete actually. Imagine a company, work studies, postpone difficulties organizing. This is the key line. Difficulties in organizing work with poor concentration. Okay, all started after an event. Right. Asking what you look for to support the diagnosis. I think his anxious appearance is more important here. Yes, anxious and threatening. It looks like what, guys? It's if this is happening after an incident, okay. Any diagnosis? Is it stress disorder you would say, or post-traumatic stress disorder you would say? Because stress disorder is it's between one within a month, 3 days to up to 1 month. Post-traumatic stress disorder, acute, 1 month to 3 month actually. Okay, so it's more like I think PTSD. Do you agree, guys? I mean, it's mentioned PTSD, so I think diagnose is PTSD as incident started following an event. So I think this one, but still a few things in this question are a bit confusing. See, I mean, someone asked me nice question. I mean, why not judgment? See, for a judgment, it has to be more like depressive mood, actually, So there's another version, like, like if it's a depression related, there is a three conditions we find. One is a grief. So grief is usually like, kind of under um, 2 months. All right, within 2 months, that's grief. Then add adjustment. Adjustment is like 2 months to 6 months, which can be according to, and there's the depression, no more than 6 months. But all related to depressed mode or Siggy caps. You know what is Siggy caps, right? So depressed mode or the Siggy cap criteria is actually great. All right, we keep that one. It's a good one. I mean, someone else actually. Right. So it's not, I don't think so, going under depression because there's nothing much information about the depressions actually. Okay. You were seeing a patient of your colleague prescribing thyroxine without checking thyroid function test. She had weight gain. This was a trendy question last year actually. Let's see what question comes this year. That no other indication of hypothyroid. Now, are you going to report about it to AFRA or talk to the colleague when you return from holiday? Take the patient under your care. I think it's not a that big crime he has committed or something. You can also talk to your colleague after coming back from the holiday. The relation between the colleague and this is also important. Okay. Just give me 1 second, guys. Check this question and go through it. Thank you. All right, guys. What do you think, guys? So, a 10-year boy started stimulant for ADHD. Now, can you tell me what are some of those stimulant of ADHD? I mean, the name, drug names. Yeah, methylphenidate or dexamphetamine. These are the two things actually. Correct. Mhm. Now coming to this one, what do you think? Now what to do in this case? Now the boy is too small to talk about advantage or disadvantages. I think it's better talk to the parents and tell them the importance of the drug, giving that medication. Like often because they are kids, so parents don't want to give any medication, which is common in practice. So it will be better that you convince. There's a word often used in MC. If you're preparing definitely for MC, please get familiar with the word, persuade. Okay, so sometimes they also use that word. Persuade means like a little argument, not big, like a little argue with the parents. Like, no, it's really helpful. I think you should go for that one. This, that, actually, little persuade in some cases, or insist in giving the drugs. Convince, yeah, better word, like a better, yeah, convince. ADHD, some informations. Yeah, okay, here we go. This one I was looking forward. This might be useful for you. Yeah, now you can see methylphenidate, dexamphetamine. Time to time, in many years, I have seen coming this question. And about ADHD, last year was so many questions. So very important for this particular year as well. So two of the common drugs like methylphenidate and dexamphetamine, some here's few important thing. So potentiality of getting abuse or this thing is more higher with dexamphetamine. This is one important information. And another one which came in one of the exam, um, we check the age group. So generally before the age of 6, generally not recommended. So methylphenidate, so it's kind of generally not recommended in very young if needed. Use under caution. Typical not recommended, but use is less common than methylphenidate. So these are the two lines. Right. So methylphenidate is something at least under supervision we can use it actually before the age of 6. Normally, from the age of 6, we start giving these two drugs like methylphenidate and dexamphetamine. But before that, we don't use it. But if we use it in that case, probably we go for methylphenidate in that case. Why? Dexamphetamine has a more chance of getting resistant or abuse, like property is more actually. Okay, clear everyone? So methylphenidate is like a it's difficult. I didn't find it any book actually which one is really a choice actually, like a very young. So I think this one is more like a choice in kind of age groups like this actually. Yeah. All right, yes. Next one. A 16-year boy presents to the clinic. Sorry, I had to keep the phone on because a service team was coming to correct the filter of the office actually. So anyway, so in advance apologies if I have to take a call actually. 16-year boy, old boy presents to the clinic expressing concern about his physical appearance. He feels his shoulders are too narrow and has been going to the gym regularly, and but he still feels unhappy with his body. What is the likely diagnosis? Let's check this one. Clinic expressing concern about his physical appearance. Express concern about his physical appearance. He feels his shoulders are narrow. This that so. Please come up with an answer an option. Here the mention body dysmorphic, anxiety, but you could be given option like somatization and other things too. All right. So in that case, it will be real challenging in future. So this one is nothing but body dysmorphic disorder. Body dysmorphic disorder, a potential for plastic surgeons as well. All right. So for body dysmorphic disorder, they feel like it's not perfect. So in order to get more perfect, they ask plastic surgeons maybe. All right. So body dysmorphic. Yeah. All right. You can check our SMA notes. There are more significant differentiating point body dysmorphic disorder versus somatization disorder, right? Versus conversion disorder. Okay, so those points are given. Check our SMA note, from the notes section in that case. Okay. This one was easy because only psychiatric thing was given as a body dysmorphic, but when it is mixed with somatization, conversion, and some of the other points of the psychiatry, it gets confusing at time actually. This one is an easy one actually. Particularly having problem with appearance, thinking it's not the best one, it's going with the body dysmorphic disorder. Okay, so after a C-section, I mean, not mentioned is hypertension. It's like a typical on the recall line. It's a possibility it can be placenta accreta. I didn't find that much information about that one, but it's a possibility of this question of being placenta accreta, I think. Yes. Other than this placenta accreta, there's two questions that is very popular in the main exam: placenta um, previa and abruptio. All right, abruptio. Even by the way, abruptio also came last month, which is very popular. One of them is related to pain, which is which one do you think is related to pain actually? So abruptio is related to pain actually, abruptio placenta. So please, we in our note section there's a thing called obstetrics note, SMA note. So we have a full set of note from the obstetrics because obstetrics is not well given in the John Murtagh, by the way. So please check that note and appreciate placenta previa. Please read it very well. Very, very important for the exam. Okay. Elderly woman develops sudden confusion and agitation and repeated speech after being informed about a significant fire involvement in her house. Okay. Keyword: in emergency, her improved condition improved. She still exhibits some difficulty with the recent time. Based on the question, what is the most likely cause of her symptom? Keywords are confusion, agitation, repetitive speech. Now it's between A and B. So delirium, I think sudden confusion, agitation, and level of things are affected. So if it's an acute stressed reaction, first of all, the confusion thing will not be there. Do you agree, guys? If it's a acute stress reaction, the confusion thing will not be there. Here, they mentioned about the confusion word actually. So that's why you're thinking more as a um, delirium. Now we can discuss that. Is it delirium? Is it dementia? Or is it a TIA? Now, is there any neurological association? Okay, is there any neurological association? Yeah, so we don't have any um, organic problem mentioned, like a patient with a hypertension, patient with heart disease, something like that, or a focal neurological deficit, one side is hyperparesis or something. Nothing really mentioned like that. So I don't think so. It's a TIA. Nothing mentioned about depression. That's out of the option. Okay, so nothing really mentioned that gradual memory loss, like Alzheimer's. That's the thing. All right, so that's important. I think we do have another 20-minute class left. I think, yeah, someone I think uh, started having delirium, I guess, already. All right. Mm. Yeah, because it's sudden. Okay, so because delirium by like a one of the condition which is sudden onset of confusion, agitation, and these things are common actually. Yes. And we can see delirium people already actually in our class actually. All right. We're getting confused. All right. Jokes apart, I mean, nothing. Okay, no, but I respect that sometimes people have, I think, small kids, this, that. In that case, maybe crying, or the small babies are crying, or maybe some cases, big babies also crying actually. And all right. So, whatever it is, the reason, You can leave the class if it's okay. If you don't have a choice, we can give you the treatment later. That's okay. Now, coming to this one, patient on oxycodone for back pain and recently started heroin actually. Okay. Oh my God. So tough drugs actually. Okay. We have question till 40 by the way. Non-sitting pain management. So are you going to give him the oxycodone or increase the dose of the oxycodone or giving a new one? Sometimes there was option missing, I think, giving a new one. Or if you see, he is like, he got opioid for his back pain. So probably he has a habit that has developed. Okay. And he recently started another one. So probably he started getting addict. So he needs the same group of drug from the doctor or the pharmacist actually. So this is a patient for sending to rehabilitation. Dependency thing has happened. So B is the right answer. So B is the right answer actually. Before updating or posting this file, I will also add a some one to little reference. I will double check the file again. So don't worry about it. So we can add this one as a case of, yeah. Okay. All right, guys. Okay, premenstrual, like some of the symptoms, premenstrual symptoms, like a what type of symptom are you expecting? Like a premenstrual symptom. There's a chapter in the John Mottag about the premenstrual, right? So I think it's not a difficult question. I mean, some of the premenstrual symptoms. So in that case, uh, which one would be better? So I think the best possible would be to going with a lifestyle modifications. What do you think? So I think lifestyle modification will be better. Uh, What I can predict from this question is little like a messy, that we call part. Maybe some CBT has been started, but it's probably not enough of an. So in that case, more things to be added, more things to be added. Well, under the lifestyle, actually, yeah. The patient has a normal menstrual cycle. Okay, it depends on the question. If the question says the conservative failed, then we can also go through some drugs. Like, can you tell me some more option other than the conservative, like counseling and reassurance? Other than, can you tell me more options? Yes, there's some evidence-based things like vitamin B complexes, Primose oil, right? Uh, this thing has some effect, but ultimately, if everything fails, then SSRI actually. Mhm. Now, premenstrual, like a premenstrual means, I mean, like there's a two chapter. One is the menopausal, one is the premenopause. It's about to stop actually. So hot flash, this thing has started actually. Okay, PMS. Please check the chapter. There's two different chapter in John Martha. One menstrual and was a premenstrual. Just before having menopause, that's the premenopause, not menstrual actually. Pre-menopausal actually. I think this is pre-menopausal. I think no, I think we should correct this. We directly copy pasted from the article. Pre-menopausal. You are right. Pre-menopausal symptom, like, yes. No. Yeah, peri, both you can say it's fine. Okay. Next one, a lady dependent. Okay, so last one answer, and it depends on what they will ask, maybe lifestyle. But if in the main exam, if you find that already conservative, even if it is failed, then we can try something new. Lady dependent on diazepam, 20 milligrams, sleep recently off, now sweating, tachycardia and agitated. What is the treatment? I think this is clear, dependent on diazepam. Recently, it's off now. It's a drug. Yeah, she has a dependency, so I think need to give the diazepam and slowly tapering the dose. Slowly tapering the dose. So benzodiazepine withdrawal timeline. Have a look on this one. I'll be taking 1 minute. All right, guys. A similar type of question you will find like a paracetamol poisoning timeline type. Do you remember that, guys? Paracetamol poisoning. If you want, I can show you. A similar type of question, which is also popular in the exam. Paracetamol poisoning. Yeah, this is very popular. Often it comes like they can give you a question. There was suspected paracetamol poisoning 5 hours back. What to do next? Give charcoal, uh, measure serum paracetamol level, or N-acetylcysteine infusion or NAC infusion. So if it says 5 hours, then measure serum paracetamol level. Okay, great. So it's a similar. I mean, this timeline type things are very very popular in the exam. A man concerns about his CA prostate. He has never had UTI large symptom. The father was diagnosed with CA prostate, maybe 8 years old. 8 years old. Neighbor has a metastatic prostate cancer. Told him there is a test you can detect CA prostate before it gets metastasis. So what to do in this case? Now this question has been tested um, with the world. Tell the patient about the pros and cons, and it was the answer. Okay, so if I make a option 5 and telling that mm, reassure the patient and tell the patient about the pros and cons about the prostate cancer. So that's usually the answer, but which is not present. Option 5. Among the options, PSA digital ultrasound and come back when symptomatic something is given. Now, in that case, tell the patient come back when symptomatic actually. All right. So this is nearly close. We will not do the PSA testing. A man concern, his age is missing, but a man concern, maybe his age is like 35 or yeah. His father was diagnosed at so old age. Okay. A quick question. Do we do prostate cancer screening? Do we do prostate cancer screening as like colon and breast? Colon cancer and breast cancer, we do a regular screening. Prostate cancer, we don't do. So that's the answer. Please read from the RACGP guidelines, or you can type RACGP and type breast cancer, colon cancer, prostate cancer, these things actually. Okay, great. So this one, our final answer is 4. It is correct. Anyways, Even if you do the PSA testing, more than 20, highly suspected. Okay. A child come with only difficulty in drinking water. Here is the problem. Maybe a dysphagia and urticaria and some allergic situations as well. So dysphagia plus allergy. Or maybe some cases in the question they will give you history in the family as well. So this one is not globus, not a faking, but this is some sort of allergy. Eosinophilic esophagitis. Eosinophilic esophagitis. Now, with the eosinophilic esophagitis, you will also find in John Mutter. I'll show you it in a second in a John Mutter. Yeah, eosinophilic esophagitis, popular topic from John Mutter. Here we go. I'll be showing in a second. Yeah, from the 8th edition. Cause of dysphagia, where you find this one, with some allergic associations. It can be skin, asthma. Some cases they give you IgE elevated. So as a treatment, what we give him is a steroid, which is important. As like any other esophageal condition, we also do barium, but at some point we can do endoscopy. Now, this is not given in John Muttad, and also important for you to know because it has been tested. Endoscopy will show multiple constrictions. This is an extra key line to learn. I mean, we also tell you which is not present in the books actually, and which is tested in the exam. So barium solo, as like every esophageal condition, so we'll do it. For allergies, we can do some allergic tests, and of course, endoscopy wise, we'll find multiple constriction or eosinophilic esophagitis. I hope that's clear to all of you for this question. Okay. Young girl choking after eating nugget relieved on drinking water. Similar episode. I think it's similar. Eosinophilic esophagitis again. Similar type of question. That particular one. All right. Okay. Esophageal related. Some other day I'll be talking. Don't worry. I'll be someday describing CERT, very, very popular in the exam. And also achalasia, I'll be describing a very, very popular in the exam, especially CERT is extremely popular in the main exam. This time we saw the eosinophilic coming, but ZERD and the achalasia are the two very, very popular often you'll get in the exam. Okay, this one is a repeat one, so we're skipping. It's autistic, sorry. Um, this will repeat it, I think. Um, this one, I think, not this one. Since speech not developed, I think this one is the answer. Right? We decided this one as a autistic. Okay. So this line was the mandatory one. Speech not developed, then we can go for that. Otherwise, encopresis can be a sign of sexual abuse. All right. Uh, the child urges to lift up the arms in the school, although he tries to control them. Very difficult to control. Therefore, ashamed to attend school. Asking about the management. What do you think, guys? So in that case, what we are going to do is starting adding risperidone because it is an atypical antipsychotic. Atypical antipsychotic, so which will have less side effects. All right. So common repetitive movement, it can be an OCD, yes. Okay. Here's a question, and this type of question we get to see often in AMC exams. 5 year immigrant Sudanese baby came in for routine checkup. His diet is like a low dairy diets or something. Routine examination revealed low serum vitamin D level, otherwise healthy, and no skeletal deformity. What's the most appropriate next step in the management? The person is already having vitamin D level deficient. So only going to the sun will it be enough actually? They are asking most appropriate next. So in that case, definitely needing vitamin D level or cholecalciferol thing, which is the direct active form from the outside. So this is important for all of us actually. Vitamin D as an active form is cholecalciferol. Similar kind of. Okay, so this one I wanted to highlight. This particular type of things tested very often. I'll try to add more in this recall batch, this type of slides in coming days, so that you can quickly revise a lot of things. Like example, one of those question was a Sudanese baby and vitamin D deficiency, multiple time tested in the exam. Aborigine, barefoot, ascaris, or hookworm. Already we have seen. With the Thailand, STD questions are very popular, but we have seen dengue and pneumonia with Thailand with a first week fever. Vomiting after 30 minutes. We have seen Staph aureus. Quick, like a gastroenteritis, it can be salmonella as well or diarrhea. We have seen questions like this. Working in an aniline dye factory or chemical factory gives rise to urinary bladder cancer, another popular one from this particular year. Coal mine as a occupational lung disease, very popular. Lemon shaped rash or Lyme, known as erythema marginis, so donut type things. Lyme disease has been tested. Aboriginal mom, then the kid is feeling shy. Now, is that something you want to report as child abuse? No, it's a cultural difference actually. Aboriginals are, in general, very shy. There's a chapter Aboriginal in the John Mota. You can see this line is exactly given. Okay, so this type of things I'll try to add more. In every slide, every month, something I like to add actually. As a clinchers. Let me know if this kind of things are more helpful. Give me as a feedback here in the comment section. I mean, those points, and these are some of the tested topic. I mean that uh, this particular year's one of the tested ones actually. So I thought of adding them with some highlight because when you are going through the slides, you don't have that time. So you can just quickly double check. I'll add more in that. So nutshell and this type of thing, we will add more in coming days in the slides. Actually, I can use my experiences knowing about what topics are high yield. Yeah. All right. No problem. Okay, so here is a last question, I think, about something which is happening very recent time. We couldn't collect the full form of this one, but it's suspected acute stress disorder, actually. Okay, someone, I mean, happened so fast, this thing. This one is it's a question about acute stress disorder, like develop change behavior uh, just after a big fire involved in the house, very bit actually. Yeah, right. Yeah, some confusion out there actually. The duration was not mentioned. Actually, you are right. I think it's a delirium one, I think. What do you think? Another question, developing change behavior just after told a big fire involved. She become confused and agitated. Hmm. Yeah, I think it's the same because the same month when we collect a lot of similar types there. So I think it's acute delirium, I think. Yeah, yeah, I agree. Yeah. Depends on the full. Yeah, yeah. Right. I think you're absolutely right, guys. All right. All right, guys. So thank you so much for attending the session, I think. And I'll be checking last one, two more. I think last five, six, I'll be trying to add a little bit more clinchers. Will be helpful, actually. Thank you so much for attending the session. And we'll try to add more things in coming days. It is very important, like how much, we are trying to so effort is important from my side. If I can add more like especially this type of thing. I need your feedback. I hope so. If I add things like that, which has been tested more, can be helpful. And also a few things like, example, yeah, like this in a nutshell things um, would be more helpful, I think, in coming days, which in the new courses, new batches, I'll be trying to add more of these things actually often actually. So that I always try to think that, I mean, when I'm a student, what I will look forward more actually. So before going to finals, I think this nutshell things quickly you guys can revise. Because sometimes, seeing that question, you have to read the whole one, right? Sometimes you have to read the whole question, but if there is a little things like nutshell, you can just quickly go through the slides, and 3 or 4 year, you can just quickly revise all of a sudden actually. But all right, anyways, guys, thank you so much. I hope the session was helpful. In case if anyone joins late, we started today, and I think by 30th of June, we have a expanding good course. This is the routine with some video channel accesses and this, that. Yes. So yeah, I'll be uploading the video. Check my YouTube channel. I'll be posting this one and also in the group. Yeah, it's a class one. And those of you are joining, you will already get it. I mean, you will start getting it by the Google Drive, definitely, actually. Right. So thank you so much for attending. This is the class time, and Monday, Friday, I will see you in the classes. Definitely. It's an online course. And after class, you'll get the reports via Drive. The first class I'll be uploading in the same group we're taking class, because many from outside here, and some might be missed. And in terms of the references, we'll be trying to add more. You guys will get exam support. Actually, definitely, anyone, doesn't matter, even October, November, you'll still get the exam support group, live classes, supported files, and all these things. Where to get materials, you can inbox where to get materials and give your Gmail, then we'll get back to you. What's new? A lot of new things we try to add actually. And as I mentioned, I want you guys to remind me to give a little demonstration with the materials. So I'll be giving you a little demonstration in 1 minute uh, to show you some of the material things. And here we go in a second, showing you the materials, how it looks like in a second. Yes, and just 2 minutes before we cut off. So he will be receiving a folder like this, MCQ recall course. When you enter into that recall course, those of you who are still with us can see that. So till 2025, let's see. Yes, till even April we have been updated. Yeah, April is ongoing. So how much we are updated, you must be knowing. But still, we are taking the live classes. Those things we'll be also putting here in any way. Okay, and even if you see 2024, if I click one of the folder, November's example, see, I mean, file folder, this is video. Yeah, see, video links are coming, and see, PowerPoint links are coming. All right, so every month has things like that. Even if you check, it's there. Yep. So see again, yep, video link. Yeah. Okay, any another month, let me check. Is it 2023? Any month? Okay, November, let's say. Yep. Right. Yeah, that's a video. Yeah, that's me. File folder, file folder. So everything is there, 2021. And of course, MC notes by Dr. Shahriar. You can go alphabetically. Small tip here, some people's Google Drive organized in this way. Like things come in a big thumbnail. You put it as a list view. This view is more better. What do you think? So if you read in this way with G gynae notes, with M medicine notes, so many medicine notes, all systems, pediatric notes, psychiatric notes, screening notes. So list view is more better. So with your laptop, you can change the view so that you can find things more easily. There's a search button. You can also say, I'm typing pneumonia. I can also find the pneumonia directly in that way. So that's more like magic, very easy. RSCGP guideline, this, that. So you'll find things easily here actually. All right. So let's say bleeding, effect type. So many things will come up very quickly in that way. Right. Early pregnancy, bleeding, RSCGP notes. Anyways, so you will find a lot of things easily. And this is it. Anything extra class, extra thing will be putting in extra, but this is in general. So example, today's class we are taking today, June 2024. So this class will be going here, June 2024 already, because we have been taking classes. It's there, but we keep updating, keep taking classes. So the new one will be also posting here. So another new video link will come back here actually. If you haven't received materials, you will get it tomorrow. I mean, or if you are up to look forward to join the course, you can also let us know. Thank you so much, guys. I'll be active again tomorrow. So leave me a message. In that case, if you haven't received, we'll get back to you shortly. In that case, thank you. Good night.